Welcome to the series where I review the 2025 AACE Consensus Statement on the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Today I will discuss how we now understand obesity as a chronic, relapsing, adiposity-based disease with complex neurohormonal, metabolic, and behavioral drivers. Behavioral and lifestyle therapy remains foundational for every patient with obesity, regardless of whether medical or surgical therapies are also being used. That said, sustaining lifestyle intervention alone over the long term is often challenging, and this is not a failure of willpower or adherence. Rather, many patients experience weight regain because of maladaptive biological responses after weight loss that are integral to the pathophysiology of obesity itself. Achieving an energy deficit for weight loss can be accomplished through a variety of evidence-based dietary strategies. These strategies are not mutually exclusive and can be combined or modified in a personalized manner. Importantly, dietary patterns should be optimized not only for weight reduction, but also for broader health benefits. They should reflect individual preferences, cultural context, health goals, and access to food. This becomes especially important for patients experiencing pronounced weight loss, including those treated with highly effective second-generation obesity medications, where special attention to diet quality is required to ensure adequate intake of both macronutrients and micronutrients, such as protein, fiber, iron, and calcium. Nutrition and energy intake are central regulators of energy balance and adiposity. An exclusive focus on calories in, calories out oversimplifies the biology of obesity and contributes to stigma. While weight reduction does require a sustained shift in energy balance such that energy utilization exceeds energy intake, maintaining a healthy intake of both macro and micronutrients is essential to preserve muscle mass, bone health, and overall metabolic function. Accordingly, nutritional interventions should emphasize food quality and nutrient density while minimizing ultra-processed and energy-dense foods. This must occur within the context of psychosocial realities, cultural norms, and individual preferences. Although an energy deficit is required for weight reduction, the manner in which that deficit is achieved matters greatly for safety, sustainability, and health outcomes. Individuals should receive counseling and structured support to develop personalized nutrition plans that respect autonomy, accommodate personal and cultural preferences, and align with weight and health goals. Numerous reduced-calorie meal plans with variable macronutrient composition can safely promote weight reduction and health improvement. When lifestyle intervention is used as the sole therapeutic modality, conventional guidance recommends daily caloric deficits of approximately 500 to 750 kilocalories, or estimated intakes of roughly 1,200 to 1,500 kilocalories per day for women and men, respectively. These estimates are typically based on baseline energy expenditure calculations used in clinical trials across a broad range of dietary patterns, including Mediterranean-style, DASH diet, complex carbohydrate, low-carbohydrate, plant-based, and paleo-style diets. No specific macronutrient composition has demonstrated clear superiority. Instead, the most effective dietary intervention is the one a patient can adhere to long-term. Importantly, long-term safety data beyond 2 to 3 years are limited for many of these approaches, and long-term cardiovascular risk reduction has been demonstrated only for the Mediterranean dietary pattern. Meal replacement strategies and timing of eating or fasting can be incorporated flexibly alongside other personalized dietary interventions. During periods of active weight loss and during dose escalation of obesity medications, ensuring adequate nutrition becomes even more critical. With the potent appetite suppression seen with second-generation obesity medications, the emphasis shifts away from simply reducing caloric intake and toward preserving diet quality. Key guiding principles include prioritizing nutrient-dense carbohydrates such as vegetables, legumes, and fruits, prioritizing lean protein intake, considering multivitamin supplementation that includes iron and calcium, and using meal replacements flexibly when appropriate. To mitigate gastrointestinal side effects commonly associated with obesity medications, patients can be counseled to eat slowly, consume smaller and more frequent meals, reduce intake of fatty or trigger foods, track foods that exacerbate symptoms, and maintain adequate hydration. Protein deserves particular emphasis during weight reduction, as it is the most critical macronutrient for mitigating lean muscle loss. Earlier concerns that high protein intake accelerates chronic kidney disease progression have not been supported by evidence. Current guidance suggests maintaining protein intake of at least 1.2 grams per kilogram of body mass per day for most individuals, and at least 0.8 grams per kilogram per day for those with diabetes and chronic kidney disease not treated with dialysis. Higher intakes, up to 2.3 grams per kilogram per day, may be required to maximize lean mass retention when resistance training is prioritized during hypocaloric periods. While very high protein intake over prolonged periods does not appear to cause harm, the tolerable upper limit is thought to be approximately 3.5 grams per kilogram per day. Turning now to physical activity. Physical activity, including aerobic activity, resistance or strength training, reduced sedentary time, and increased non-exercise activity thermogenesis, plays a critical therapeutic role in improving overall health in people with obesity. Although exercise alone may result in modest weight reduction or weight neutrality, it provides meaningful benefits for insulin sensitivity, body composition, cardiometabolic risk factors, psychological well-being, and weight maintenance. An individualized physical activity prescription aligned with patient preferences and functional limitations is essential. A general target is 150 minutes per week of moderate intensity aerobic activity, distributed across at least 3 days. Whole body resistance training at least 2 to 3 days per week should be prioritized, especially in the context of intensive medical or surgical weight reduction to preserve or improve lean muscle mass. For long-term weight maintenance, higher volumes of activity are often required, typically 200 to 300 minutes per week of moderate intensity aerobic exercise, again with resistance training as a central component. Resistance training during active weight loss helps preserve resting metabolic rate and total energy expenditure. This is particularly critical in older adults and individuals at risk for frailty or sarcopenic obesity, where loss of lean mass can lead to functional decline, increased fall risk, and fractures. Adequate protein intake must accompany resistance training in these populations. Physical activity goals can be difficult to achieve initially. 2 principles apply. Begin at a low intensity and increase gradually as tolerated. And remember that any activity is better than none. Simple strategies such as brief walks, increased standing time, chair-based or water-based exercises, and referral to physical therapy can help patients with limited mobility safely initiate activity. Structured medical fitness programs may also be useful when available. Sleep represents another critical and often neglected domain. Short sleep duration and poor sleep quality promote dysregulated energy intake, metabolic disruption, and increased obesity risk. Inadequate sleep and circadian disruption are associated with increased appetite, increased energy intake, reduced energy expenditure, and heightened cardiometabolic risk. Individualized sleep hygiene counseling aimed at extending sleep duration may reduce energy intake and promote weight reduction. Obstructive sleep apnea is a common but underdiagnosed complication of obesity. Its relationship with obesity is bidirectional and complex, and both conditions are associated with insulin resistance and increased cardiovascular risk. Weight reduction improves sleep apnea severity, whereas treatment with CPAP alone does not result in weight loss. Patients with obesity should be counseled on sleep health and screened for sleep apnea when symptoms, neck circumference, or clinical risk factors are present. Finally, we must address bias, stigma, psychological disorders, and behavioral therapy. Weight bias refers to negative beliefs about people living with obesity, while weight stigma reflects discriminatory behaviors resulting from those beliefs. These dynamics affect clinical care and create systemic barriers to treatment. Internalized weight bias occurs when individuals apply negative stereotypes to themselves, leading to self-devaluation. This is strongly associated with poorer physical and mental health, reduced adherence, lower motivation for healthy behaviors, and worse outcomes. A person-centered approach using person-first language and empathy is essential. Patients should be presented with the full range of evidence-based lifestyle, medical, and surgical treatment options, with communication tailored to health literacy. Cognitive behavioral therapy can support sustained lifestyle change by addressing maladaptive thought patterns and behaviors. Depression, anxiety, and binge eating disorder are more prevalent in people with obesity and may require early intervention. Psychological screening and referral should be considered part of comprehensive long-term obesity care. In summary, behavioral and lifestyle therapy remains foundational in obesity management, but it must be biologically informed, individualized, and integrated with medical and surgical options when appropriate. Nutrition should prioritize diet quality, adequate protein, and micronutrient sufficiency while achieving an energy deficit. Physical activity should be individualized, progressive, and resistance-focused to preserve lean mass. Sleep health must be addressed proactively. Finally, addressing bias, stigma, and psychological health is essential for durable outcomes. Effective obesity care requires treating the whole person within their biological, psychological, and social context. This was another bite-sized episode of Endo in a Bite. In the next few episodes, we will be working through the details of the AACE consensus statement, the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease, the 2025 update. Remember to visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam prep. Let's get through this document one bite at a time.